Okay, welcome everyone. We will continue with pulmonary medicine. "39-year-old man with obesity hypoventilation syndrome hospitalized for hypoxemia and altered mental status. Oxygen saturation is 96 on 50% oxygen. He is somnolent but awakens to light touch. CXR shows small lung volume, normal heart, and normal vascularization of lung parenchyma. Period. 3 hours ago, pH was 7.2, but now is 7.1. What is the best treatment? Question mark. So this guy with obesity hypoventilation syndrome, hypoxemia, altered mental status. He's getting confused. Mental status is decreasing, right? And he's on BiPAP, right? That's how you treat the obesity hypoventilation syndrome. However, even after BiPAP, 3 hours later, pH dropped, so he's becoming more acidotic. So how do you behave next time? What do you do right now to save this patient?
I think he's getting so basically I think he cannot control his oxygen level, so I think you should intube him.
Perfect, yeah. So whenever BiPAP is like the highest measure of invasive ventilation, if that didn't cut it, just intubate the hell out of them, okay?
Yeah, but can you make your screen this dictation one a little bigger?
Endotracheal intubation is needed because the patient ABG did not improve after BiPAP, period. Next paragraph. 42-year-old man evaluated for follow-up of progressive dyspnea of 2 years duration. Examinations shows no clubbing or JVD, and chest X-ray showing hyperinflation and diaphragmatic flattening. The patient has not smoked in 20 years, question mark. DX. So this guy, young guy, emphysema picture and hasn't smoked. What is that, the diagnosis?
Is it the TNF insufficient, the TNF? Not TNF.
You mean alpha-1 antitrypsin deficiency?
Yeah, that one.
Yes, that's it, okay. Alpha-1 antitrypsin deficiency. Next paragraph. A 46-year-old man evaluated for problems with auto-adjusting positive airway pressure that was prescribed 3 weeks ago. He awakens with sore throat, nasal congestions, and occasional headache due to the machine. What's the appropriate treatment to mitigate these symptoms of BiPAP, period? Question mark. How do you decrease the mucosal irritation? So this is common complications of BiPAP. If you use BiPAP, sometimes patients can have, because dry air all the time running through their nasal passages could cause some irritation, and they develop these symptoms, sore throat, nasal congestion, right? So how you mitigate these symptoms? You do heated humidification, okay? Heated humidification to decrease mucosal irritation with BiPAP. Next paragraph. 42-year-old woman evaluated in the office following recent hospitalizations for asthma exacerbation. Labs showing leukocytosis 10,000 with 650 eosinophil. And IgE level is 12. FEV1 is 56% of predicted. What's the treatment? Question mark. So what is the normal FEV1?
Above 80, right?
Yeah, no, around 80.
Around 80, yeah.
If it's more than 80, that's restrictive lung disease. If it's less than 80, that's obstructive lung disease. So this patient has a bad asthma, right? And then I can give you more clues. Okay, so the patient is on mometasone/formoterol, montelukast, tiotropium, and prednisone. So this is also like the question, the treatment of COPD. This is treatment of asthma, right? So if the patient on all of these medications, right? So if they tell you, okay, the patient on these three, what else to add? You add this. The patient on these three, what else do you add? You add this. But this patient took a next step. So patient has on all of those. What would be the next step that someone have eosinophilic asthma, right? There's a monoclonal antibody that mitigate eosinophilic asthma, right? And that name of monoclonal, do you remember the name?
No.
Initiate trial of mepolizumab therapy for uncontrolled eosinophilic asthma. So this is like the kind of IgE antagonist, like it's kind of like omalizumab or mepolizumab. So it's like kind of, it acts directly against eosinophil or their product, the IgE. Okay, so it's kind of it's a monoclonal antibody to interleukin 5 that reduce exacerbation of severe asthma. Okay. So that's kind of the idea of this question. Next paragraph, we have a 79-year-old woman brought to the emergency department after she was found unconscious in her apartment by neighbor. On exam, vitals are relatively stable and pulse ox shows 100% oxygen saturation on mechanical ventilation using 50% oxygen. She is unresponsive to pain or voice but has intact normal deep tendon and brain reflexes. Co-oximetry shows carboxyhemoglobin level of 50%. What's the treatment? Question mark. What do you think? What's your diagnosis first? You gotta diagnose, treat.
Looked like she was like having it says carbon monoxide poisoning.
Yeah, that's whenever you see carboxyhemoglobin, basically just tell you carbon monoxide. So how do you?
If it's above 25, right? Consider.
Yeah, 50%. Like even from clinical picture, she's unresponsive. So what is the best treatment for carbon monoxide poisoning?
100% oxygen, but then.
What do we call that?
Huh?
Yeah, that's 100% oxygen because it displaces the carbon monoxide molecules. Okay.
Yeah.
Hyperbaric oxygen therapy. Indications include loss of consciousness, ischemic cardiac changes, neurological deficit, significant metabolic acidosis, or carboxyhemoglobin level greater than 25%. Period. Does that make sense?
Yeah.
Got it? These are the indications you do hyperbaric oxygen. Got it? This is another easy question. Next paragraph, 55-year-old man with COPD presented with worsening dyspnea and he has end expiratory wheezing throughout. Oxygen saturation is 90% on room air. We did CBC and CMP are normal. What other diagnostic tests you want to order? Question mark.
ABG, chest X-ray.
ABG. Perfect. Good job. So ABG, chest X-ray. That's a good idea. So that's kind of the idea. Just want you to know the workup for someone with COPD exacerbation. Okay. ABG, X-ray. Perfect. A good answer. Let's get one more question. Next paragraph. 35-year-old woman evaluated for 4-month history of exertional dyspnea and 1-week history of chest pressure. Exam reveal widened split S2 with a prominent pulmonic component and neck vein distension. CBC, CMP are normal. What's your initial test? Question mark.
Could be pulmonary hypertension, could be anything that
I
goes up
love it. Good job. I like how you think. That's, you see, you're getting the thing. Whenever, yeah. So it is actually pulmonary hypertension. Whenever you see like prominent pulmonic component, this is the clue. So you see, you get the idea from the cardiology review. So it looks like you got this written, you got this down. So whenever you see that, it's a tricky question. So now next time, anytime you see this cliche, just click pulmonary hypertension or no. And the way you diagnose pulmonary hypertension, usually just you want to estimate pulmonary artery pressure. Now you don't know for sure. This is like give you estimation, right? How do you confirm that?
Well, you do an echo or CAT.
Echo, okay.
CAT is good. And then if this is like a type 1, so you have to give 2 medication for it.
Yeah. So echo, transthoracic echo.
Yeah.
To estimate pulmonary artery pressure. Next paragraph, 58-year-old man evaluated for follow-up of asthma exacerbation. Bedside spirometry shows moderate airflow obstruction. FEV1 improved by 15% following inhaled albuterol. The patient BMI is 36. What's the most appropriate management? Question mark. So what do you, this guy is obese and have asthma, okay? He's already taking steroid and short-acting beta agonist, right? What else do you think would help him? Do you add beclomethasone or you just advise to lose weight?
Hold on.
He's already taking steroid, oral steroid.
Wait.
Yeah, lose weight. This losing weight actually helps. Okay. Improve asthma control. Supervised weight loss program. So for the COPD or asthma, initially you start with SABA. If that didn't improve, then you add inhaled steroid. Okay. If that didn't work, then you add LAMA. Okay. If that didn't work, then you add LABA. Formoterol, which is LABA, okay. For asthma, you can add montelukast, which is something extra, or tiotropium, stuff like that,
Okay.
Okay, so it's like that, Okay, so this is kind of the idea. Okay, let's do a few more questions and do quick review after that. And, okay. Next paragraph. 71-year-old man evaluated during a follow-up visit for sleep-related breathing pauses observed by hospital staff when he was admitted for ICD implantation. Exam revealed basilar crackles, faint and expiratory wheezing, neck vein distension, and 1+ ankle edema. Which of the following is the most appropriate treatment for the patient's central sleep apnea? Question mark. So whenever you see, this is the idea, it's very interesting. Whenever you see sleep-related breathing poses observed by hospital staff, you know, when you have sleep-related poses, what does that tell you? What's your diagnosis? Yeah, so for sleep apnea has different types. Either it could be central or peripheral, which is obstructive, okay? So this patient actually, they can even give you in the question, they tell you, polysomnography demonstrates central sleep apnea with Cheyne-Stokes breathing pattern. So whenever you see that on the question, they tell you Cheyne-Stokes breathing pattern, or if they told this is central sleep apnea. Now they were kind enough in this question to tell you the diagnosis, okay? Central sleep apnea. Now they just want you to know, how do you treat this patient? And this patient also has heart failure, because when they tell you ICD implantation, when do we usually do ICD implantation?
When there is a ventricular, like a VTAC or something, and then most likely if there's a syncope or the sudden they're dead.
Biggest one is EF less than 30%, okay? If there is EF less than 30%, okay, this is kind of give you a clue, okay? And then exam, what does that tell you? There's a Crackles, right?
Mm-hmm.
So how do you treat this patient? EF 30%, okay? What do you think the best thing that would help this patient? Has central sleep apnea and have EF. So basically the question, if I want to summarize it, how do you treat heart failure who has Crackles with central sleep apnea? What do you treat? What do you use? What medication?
Well, for the heart failure with that crackle, you always get furosemide.
Perfect. That's actually the correct treatment, because you get rid of the fluid. Whenever there's fluid, Crackles, you just give furosemide, and this helps the central sleep apnea as well. Okay. Okay. Does that make sense?
Yeah.
Furosemide. Initial treatment of sleep apnea should target modifiable risk factor, include medical optimization of heart failure has shown to improve central sleep apnea and Cheyne-Stokes breathing, should precede other therapies for sleep apnea. Okay. Next paragraph, a 60-year-old woman evaluated during a follow-up visit. She has a lifelong history of intermittent asthma. On physical exam, oxygen saturation is 95%, breathing on room air. Lungs are clear to auscultation, and lab studies shows normal hemoglobin concentration and leukocyte count with 8% eosinophil. What's the most appropriate treatment? Question mark. So for this patient, what's the most appropriate treatment? Chronic macrolide therapy, or you do inhaled steroid and LABA?
Okay, 1 second. Let me look at it one more time.
So this is a question to same like a question that you asked me. This patient has COPD and asthma. Okay. So what medications that could work for both? Is it LABA alone or inhaled steroid with LABA?
No, you cannot give steroid alone. You have to give it LABA.
Yeah, perfect. So that's actually the correct treatment. Inhaled glucocorticoid and long-acting beta-2 agonist for COPD and asthma. Period. Now let's just review the questions that we discussed today. So this first question just kind of make you know that, okay, ABG didn't improve on BiPAP, just intubate, okay? The other question, when you see young guy that never smoked and you have hyperinflation with flattened diaphragm, this is alpha-1 antitrypsin. Okay. The other questions, whenever you see somebody develop sore throat after BiPAP, just give them heated humidification. Just give them some to help mitigate the symptoms of BiPAP. Whenever you see 650 eosinophil in asthma patient, it gives you an idea. Okay, use monoclonal antibody, especially if they are on everything. Whenever you see carboxyhemoglobin more than 50, just pick hyperbaric oxygen and move on. Here, whenever they want you to know what do you order for COPD, basically CBC, CMP, chest X-ray, and ABG. They could hide one and ask you about the other. Whenever you see white split S2 prominent pulmonary component, this indicates pulmonary hypertension, so you want to do echo to confirm that. Whenever you see somebody FEV1 improve, actually by 15%, not 15% after albuterol, and BMI is high, if they are on every medication, inhaled steroid and SABA, then just do weight loss. That would be a good idea to do that. If somebody has heart failure and central sleep apnea, you want to treat their heart failure first by Lasix. If someone have asthma and COPD, you just give them long-acting beta-2 agonist and inhaled steroid. And that concludes summary of the second section of respiratory, pulmonary, and critical care. Thank you so much for listening.